Welcome to the Foot Health Facts Podcast, powered by the American College of Foot and Ankle Surgeons. I'm your host and a fellow of the college, Dr. Matthew Dairman. We're wrapping up our series on ankle sprains today with Dr. Tyler Tewilliager, a foot and ankle surgeon out of Houma, Louisiana. Welcome back, Tyler.
Thanks for having me. Excited to be here.
So we've talked about what causes sprains and how to prevent them, as well as chronic ankle instability, but today we're going deeper. When does a sprain stop being just a sprain and start being a surgical case? So most ankle sprains, as we articulated in previous episodes, don't need surgery. But when do you start to think seriously about it as a surgeon?
Yeah, I think for me, I have a very set protocols with someone comes in grade 1 through 3 ankle sprain. Almost always ends up in physical therapy if it's a grade 2 or 3 ankle sprain. When they come back and see me after that round of physical therapy, and they're not doing 100% better or close to it, that's when I start getting red flags in the head. Why aren't we doing, this much better at that 6 to 8 week mark after doing aggressive physical therapy? You've already done the immobilization stuff. It's one, is it a compliance issue? Or two, is this one of those ligaments that is going to be stubborn and not want to get a whole lot better? That's when I really start leaning into, more advanced imaging. Why is it hurting? Potentially getting an MRI at that time to evaluate further.
How often are you finding kind of, an MRI showing other issues other than the just ankle sprain, like the lateral ankle ligaments? How often is the medial involved, peroneal tendons?
Yeah, I mean, it's almost every single MRI. It's not just your ETFL that's torn, like we like to think that that's all that's injured. You can look at, a million of those ankle MRIs, and your peroneal tendons are going to be torn very frequently in those. You can have some bony contusions, osteochondral lesions of the talus, essentially damage to the cartilage of the joint from the sprain. And those are all, important things to pick up and could be, lingering injuries that are the reason why we're not getting better at that point.
Is there a point where you would order advanced imaging like an MRI before the physical therapy? Is there a certain type of patient or certain type of injury or symptom that would lead to that?
Yeah, I think, going back to those high ankle sprains, that's one where I lean a little bit more heavy into the MRI early on. For me, a lateral ankle injury, even a grade 3 sprain, I don't jump to an MRI that often just because they are pretty predictable for most people that they should get better if we do the, stepwise manner. If I am concerned of those high ankle sprains or syndesmotic injuries, that's one where I get an MRI right away because typically it's either a younger athlete or a higher energy injury, and I want to make sure we're not, missing something. And if it is torn, then potentially leads to surgery a little bit more often.
Yeah, I hate missing things, so that's why I was curious. So, what kinds of procedures do you use to stabilize an ankle that's just not holding up anymore?
Yeah, so I lean pretty heavy in just the old traditional Bruce from Gold procedure where we essentially take your ligament, tighten it back up, and I use a couple of suture anchors to do that, just to hold it in place. Really, looking more at these more modern kind of brace techniques. I hold that more for revision surgery or a young athlete that really wants to push the limits and kind of be aggressive in the rehab and get back to sport within the next couple of months. But I really prefer to do just a primary repair where I just cinch up that ligament, make it tight again, and then let rehab do the rest.
Are you scoping these first and then repairing, or are you just repairing the direct?
I don't scope every single one. That's where I lean on the MRI a little bit more. If there's some synovitis in the joint, certainly if there's an osteochondral lesion, I'm sticking a scope in there 100% of the time if they're having symptoms with it. But just a standard brostrom, I don't stick a scope in there just because setup time, and I don't. If the MRI is not showing pathology in the ankle, I'm not going to create new poke holes for no reason.
Yeah, there's a lot of different procedures out there where you reroute tendons and take allograft and foreign body stuff. I agree with you. Direct repair has worked in 20 years of practice, most every time, at least in my hands. So, is surgery a cure, or does someone still need therapy and strengthening afterward to make the most of it?
Yeah, I think therapy is the most important part. You can do the perfect surgery, and if you don't rehab it the appropriate way, then you can be right back to ground zero pretty quickly. All it takes is one you know misstep, and you re-injure that ligament, and the a whole reason we did surgery is kind of out the window. So I always 100% of the time, if I'm doing a ligament reconstruction, it is going to physical therapy afterwards. Pretty early on in the process, I'm very aggressive with it. As soon as you're walking, as soon as stitches come out, that's when I start physical therapy. I let them get their hands on and get training the ligaments to protect the ankle again.
Yeah, it's so important to set patient expectations at this point because here you have a patient that's likely failed physical therapy. Now they've had surgery and we're sending them back to therapy that they previously failed. But now it's basically a repaired ankle. So, but convincing them that yes, you still need to spend the time to rehab, so critical for them. How often are you keeping them in a brace after surgery? Are you weaning them from a boot to a brace? Like what's the recovery for most of these?
Yeah, for me, typically in a boot for the first month or so afterwards, and then in a brace for another 2 to 3 weeks, and by then physical therapy should have weaned them out the brace by around that 6 to 8 week mark. And I don't want them back in it if they're fully recovered. Physical therapy graduates them; they can protect their ankle. I like doing the single leg hop test, where if you can hop on one leg and it doesn't feel like your ankle's going to give out on you and it's strong, then you're out of a brace for me.
Yeah, that's a great piece of advice. The single hop test generally works quite well. So, if someone's afraid of surgery, even after multiple sprains, what would you want them to know?
Yeah, I think, in terms of surgeries we do on the foot and ankle, this is one of the most predictable ones with some of the best outcomes reported. Really can take an ankle that wants to roll, every time you take a misstep, step on a pebble the wrong way and give you a stable ankle. It is pretty predictable. It is surgery though, and I totally understand patients that want to avoid it. But the biggest risk, and then what I always tell people who are at this point is all it takes is one bad sprain, and then you're getting surgery for a bad reason because you broke your ankle as opposed to repairing your ligament.
Yeah. Excellent advice. Thank you, Tyler. Appreciate your time. Don't forget to put that
Thank you.
wedding date on your calendar. You need to show up for it. So,
100%. I'll be there.
if you've had more ankle sprains than birthdays this year, you don't have to live in fear of stairs and sand traps. There are real solutions out there. You've been listening to the Foot Health Facts podcast. For more information on today's topic or any foot and ankle concern, head over to foothealthfacts.org. On behalf of the college, I'm Dr. Matthew Dairman. Thanks for joining us today. If you enjoyed this episode, don't forget to like, subscribe, and share it with someone you care about. Together, we'll keep everyone moving forward one step and one topic at a time.